Hi guys, so my presentation this week for Lesson 11 is on sensory stimulation and sensory integration. So starting off, the intended client groups that this is applicable for is individuals who are older that have advanced dementia, people with developmental disabilities, traumatic brain injuries, HIV or AIDS, and people that are just suffering from any kind of pain. First off, sensory stimulation involves all five senses: sight, hearing, touch, taste, smell, and proprioception, which is the unconscious perception of movement and spatial orientation arising from stimuli within the body itself. Within the human body, these stimuli are directed by nerves within the body itself, as well as the semicircular canals of the inner ear. So what's the difference between sensory stimulation and sensory integration? Sensory integration is just a more sophisticated type of therapy that attempts to rewire the brain through specific and tiered activities. The approach differs from many other approaches because it does not teach specific skills. Rather, the objective is to enhance the brain's capacity to perceive, remember, and motor plan as a basis for future learning. The primary idea behind sensory integration is that the central nervous system is adaptable and that goal-directed, repetitive, and rewarded sensory and motor learning can result in improvements in the central nervous system and therefore improve the person's ability to receive, process, and act upon information more typically in the future. So it's just the basis for higher learning and a higher cognitive process in the future. It is based on three principles. First, learning is contingent on the ability to take up sensory information and integrate it in order to plan and organize behavior. Second, deficits in processing and integrating sensory information results in deficits in planning and organizing behaviors. And third, the ability of the central nervous system to process and integrate sensory information can be improved by exposures to increased and enhanced sensory experiences. So these are just some quick guidelines that apply to any group when providing sensory interventions. But if you guys want more information and research on specific groups like dementia or developmental disabilities, there's a ton of information broken up in Chapter 18 of the Stemborn Ward Law book. So just starting off, the first one is the intervention should be as early as possible. It was reported in 2005 that early rehabilitation has been associated with better outcomes in several brain injury patients. Second, the greater the cognitive impairment, the greater the need for sensory stimulation. Third, intensive or multidisciplinary therapy produces better outcomes for individuals with brain injuries. In 2005, it was reported that increased intervention facilitates a more rapid improvement and has the potential to lower the increased or early behavioral disorders and physical deformities such as contractures. 4, posture affects the level of arousal. Again, in 2005, Elliott and Walker cited numerous observational studies that indicated a standing position, perhaps with the help of a tilt table, improved awareness in the arousal levels of the clients. And a bonus to this is the standing position has a number of physiological benefits, such as redistributing skin pressure and the skeletal load on the body. So it's both beneficial for the mind and for the body. And 5, surroundings of the sensory stimulation experience should be free of distractions, quiet, comfortable, well lit, and relaxing. 6, the setting or format of the sensory stimulation room should be selected carefully. And if you guys want to know more information, there is a list on page 342 of the Stemborn Ward Law group that outlines different types of groups and when they're appropriate for different types of clients. 7, session length may vary to the needs of the person, but at a minimum, you should plan to engage the participant for at least 10 minutes. And 8, documentation of active participation and or body language such as eye contact, smiling, postural changes during the sessions is imperative to providing future effective interventions for the patient. 9, when appropriate, specialists are encouraged to interact with the patient during the session. Probing questions can be asked by the CTRS to encourage involvement by the patient and enhance their responsiveness to the provided stimuli. And then lastly, 10, staff using sensory stimulation should consider the individual's past history and preferences and should introduce sensory items systematically. And then also I just posted on the bottom that you guys should go to that figure in the book or that table, and it shows a lot of common items that can be used for sensory stimulation and gives some good ideas. Next is a Stimulation room. It is a multidisciplinary environment that is controlled by the individual based on his or her preferences. So it is just like a sensory room. Some potential educational outcomes include increased control and autonomy by the individual users, use of senses, and increase receiving unique input, development of motor skills, exploration and development of cognitive skills, soothing and calming agitation, and the building of trusting relationships and communications within the room with the facilitator, the CTRS. Research has shown that these type of environments in Stimulation rooms or sensory rooms are productive and helpful to individuals with autism, dementia, mental illness or limitations, dementia, and post-traumatic stress disorder, and traumatic brain injuries, or critical illnesses or chronic pain, because it kind of just acts to calm them down and help them. In a study done in 2004, it showed that it decreased agitation and heart rate, and it increased cognitive outcomes of clients while decreasing their agitation and stress. So finally, the application to TR. So there's not a ton of research on sensory stimulation within the therapeutic recreation services, but there is a lot of research within other fields that proves that it is beneficial to clients with dementia, intellectual disabilities, and so forth, and other mental illnesses. And these are a lot of clients that we work with in the field of TR. Buettner and colleagues created the Neurodevelopmental Sequencing Program, NDSP, and the NDSP addresses the behavioral, movement, and functional losses in individuals with dementia. It initially was utilized as a recreational therapy intervention, but since occupational therapy and physical therapy and nursing now utilize it as a basis for treatment. Patterson discusses the use of Stimulation or sensory rooms as therapeutic recreation, utilizing the leisure ability model as the basis for his argument. He describes the Stimulation environment as a designed process to bring about a desired change of behavior. So this accurately reflects what occurs in the functional intervention stage of the model. And then he also reflects upon the pleasurable and enjoyable nature of the sensory or Stimulation environment. And he concluded that it represents the recreation participation stage of the model. And so as a result, the use of multisensory environments can be a valued strategy in providing the functional and leisure needs for clients with developmental disabilities. So there's a ton of different things you can do that involve sensory stimulation. The Stimulation rooms, we did one in our class, and it ranged from we had input into smell, because we had essential oils go. We had tactile or touch. We had kinetic sand and beads that we could touch. We had music going and lights playing, and so it just involves all the senses, and it's easy to calm down and can help a wide variety of clients. So knowing what to do and what certain clients with certain needs require, we can use this skill to create a really effective recreational therapy program for our clients. So that is it. Thank you.